Today I'll be talking about a topic, very common topic, that is acne vulgaris. So basically, you know what is acne, pimple. In layman terms, it's called pimple, but medical term is acne vulgaris. So I think most of you have been affected by this problem, acne. So what is acne? It is commonly referred as chronic inflammatory disorder of the pilosebaceous unit. What is pilosebaceous? Is the sebaceous gland which is attached to the hair follicle. So in our skin there is a special glands called sebaceous glands which secretes sebum, that is the skin oil. You see oily skin. So in the face we have the sebaceous gland. So any disorder on that, one of the disorder of that gland is causes acne. So basically, what is the pathogenesis? It is abnormalities in the sebum production and follicular desquamation, bacterial proliferation, and inflammation. So basically, acne has this all these four pathogenesis which causes the acne. So not only one factor, there are basically four factors which causes acne. So it is the most common cutaneous disorder, very commonly we see, and it may cause significant psychological morbidity, rarely mortality due to suicide. Physicians should be familiar with acne vulgaris and its treatment, and it affects all races and ethnicities with equal significance. Darker skin patients have high risk of developing post-inflammatory hyperpigmentation and keloids. Post-inflammatory hyperpigmentation means the black and the dark spots which remains after the acne gets resolved. কালো দাগ কালো স্পট পড়ে যায় ব্রণের পর, তো ওটাই পোস্ট inflammatory hyperpigmentation. So hyperpigmentation is the term we use in medical term, we use for black spots or brown spots after any inflammation. Keloids, I think you heard of keloids? Keloids, like after any injury or burn, there is excess fibrous tissue on the skin. So it is a polygenic and multifactorial. What are the bacteria which causes acne? That is Propionibacterium acne or Staphylococcus epidermidis. Colonization. This bacteria is already present in our skin, but due to some factors, hormonal, environmental, dietary factors, this bacteria proliferates and causes acne. So it is found in the deep follicles and stimulate the production of pro-inflammatory mediators and lipases. Inflammation and immune response. I think in pathology you have done your pathology, right? Pathology is complete. So you have studied what is inflammation. So what are the various process or stages in inflammation? So it causes inflammation and immune response. Inflammatory cells and mediators efflux into the disrupted follicle, leading to development of papules, pustules, nodules, and cysts. And this sebaceous gland hyperplasia and excess sebum production. So during acne there is excess sebum production, increased activity of sebaceous gland, and sometimes increased size of the sebaceous gland, and abnormal follicular differentiation. So there is excess keratinocytes which gets deposited. So you see black head, white head. So that is abnormal follicular differentiation. So this is a microscopic structure of Propionibacterium acne. So pathophysiology. So the initial step in the development of acne is the formation of microcomedon. Follicular, you have heard of keratinocytes. I think last in anatomy madam had taught what is keratinocytes. So follicular keratinocytes that exhibit increased cohesiveness do not shed normally, leading to retention and accumulation. So basically when our skin gets dead, so it scales off. Sometimes we see, sometimes we don't see. But in acne, in the pilosebaceous structure, the abnormal, the keratinocytes gets adhered. So there is deposition. So androgens stimulate enlargement of sebaceous glands and increase sebum production, and the abnormal keratinocytes material and the sebum material collect in the microcomedon. So basically acne starts at puberty because there is hormonal changes. There is increased sexual hormones, the androgens like estrogen and testosterone. So they in that stage that stimulates the sebaceous glands and causes excess secretion of sebaceous sebum. So this leads to build up of pressure and whole lamellar concretions develop. At this stage, a non-inflammatory comedo may be seen. So basically, that I am talking about the blackhead and the whiteheads. You see whiteheads and the blackhead. So it is a non-inflammatory part. There is no inflammation. Inflammation comes when there is redness, pustules, pain. Then there is inflammation. So you see this is the sebaceous gland and the hair follicle in the middle. So you see that the excluded material causes inflammation and infection in the surrounding skin. Walls of the pore thin out, then rupture. So this is the inflammatory pustule. So the microenvironment allows the proliferation of bacterium, which is part of the normal flora of follicles. Bacteria is always there, but due to some factors, it increases its activity. The gram-positive rod has low virulence, but is capable of metabolism. This is not that important. So basically, this metabolism is its ability to activate the complement produces pro-inflammatory mediators, including neutrophil chemoattractions. I think in pathology, you have learned the process of inflammation. So basically, all inflammation has this common thing. So there is influx of neutrophils, inflammatory mediators, and chemoattractants. With increased pressure and recruitment of inflammatory mediators, the microcomedo may rupture and release the immunogenic keratin and sebum, thus stimulating an even greater inflammatory response. So the non-inflammatory lesion becomes the inflammatory lesions. So depending on the specific inflammatory cells present, suppurative pustules or inflamed papules, nodules or cysts may develop. If a sufficient amount of inflammation and tissue damage results, post inflammatory hyperpigmentation and scarring may result. So when basically the dermis gets damaged, then the scars happen. Okay. So basically, when there is damage of the dermis, so the second layer of the skin, and then the scar, you see the scars now after acne. If you so that is the damage is beyond the pilosebaceous unit, then it causes scarring, and scarring is permanent. So you see the process: early comedo, then later comedo. So you see there is increased deposition, then inflammatory papule and pustule and cyst. So clinical manifestations, what we see is closed comedo, that is a whitehead. So what is whitehead? A clogged follicle. Whiteheads usually appear on the skin as small round and white bumps. Open comedo, that is a blackhead. A plugged follicle that opens and turns dark at the surface of the skin. Blackheads do not indicate the presence of dirt. Papules, so inflamed, when these comedones become inflamed, it causes papules, inflamed lesions that appear as small pink bumps on the skin. Pustules, that is inflamed pus filled lesions that are red at the base. Cysts and nodules, large inflamed pus filled lesions deep under the skin that cause pain and scarring. So what are the local symptoms? That includes pain and tenderness. When there is inflammation, it includes pain and tenderness. Systemic symptoms are very rare. So severe acne can cause fever, psychological impact of the patient. Accumulation of sebum converts a microcomedo into this. So you see the pictures. So you see there is sebum converts into microcomedo. So this is the whiteheads. So this is like blackheads. You see melanin plus packed keratinocytes. When it gets exposed to air, it gets oxidized and becomes dark color. So this is blackheads. So very commonly, I think you have seen. So this is one of the graphical representation of acne. So you see closed comedo, but when in the front, and you see the back, when that closed comedo gets exposed to air, it turns black due to oxidation. So then it becomes blackhead. So but when this comedon becomes filled with pus, it becomes pustule or inflamed acne. So this is nodular cystic acne. So you see severe form of acne. So there are a lot of cysts because there is when the acne becomes more severe and chronic and long standing, it becomes cystic acne. So what are the classification? We see type 1, type 2, type 3, type 4. Type 1 is mainly comedones, small inflamed papular pustule, no scarring. Type 2 is comedones and more numerous papules and pustules, mainly facial and mild scarring. Type 3 is numerous comedones, papules, pustules spreading to the back, chest and shoulders with occasional cyst or nodule, moderate scarring. And type 4 is numerous large cysts on the face, back, upper trunk and severe scarring. So, there is grade 1, grade 2, grade 3, grade 4. Okay. So, how to diagnose? It is clinically we diagnose. We do not have to do special test for this. So, you just clinically diagnose, complete history, endocrine function, like most women with PCOS, polycystic ovary disease, suffer from acne. So, you have to check the endocrine function. Then rapid appearance with virilization, menstrual irregularity. Then there are some disease which cause excess testosterone secretion in women. There are some tumors, so which causes like man-like features in females. Then complete medication list. Some medications also cause acne, like contraceptive pills and all. Physical examination, local. So these are you have to see the site, location, what type of lesions, which grade, and whether there is scarring or not, PIH is there or not, sites involving other than the face. So basically, no laboratory examinations are required except to rule out any hormonal disbalance. So you do some hormonal test, FSH, LH, pre-testosterone. So these are like more of like hormonal part. So not to get details into this. We don't go details here. So before prescribing any kind of medications, we always do CBC and LFT. Sometimes we do serum lipid profile due to some drugs which causes some side effects on liver and cholesterol, lipid profile. So before, there are some drugs, I will come later. So before giving out systemic anti-acne drugs, we have to do some investigations. So differential diagnosis, there is different, you know what is differential diagnosis? Means there are other skin lesions which looks like acne but it is not an acne. So in skin, differential diagnosis is very important. For any short note, differential diagnosis should be a part in your short note while describing any kind of, any questions come on skin lesions, like any kind of disease like acne or scabies or any kind of psoriasis. So differential diagnosis is very important. Even if you become a dermatologist, you should know differential diagnosis, because there are many skin lesions which look same but they are totally different. So acne mimic, basically they are mimickers. So in face there is folliculitis, pseudofolliculitis barbae, rosacea, perioral dermatitis. In trunk there is malassezia folliculitis, hot tub pseudomonas folliculitis, Staph aureus folliculitis. They are not acne but they look like acne. So basically now we come to the management of the treatment part. So we give topical and oral, topical or oral, or topical with oral. So basically for grade 1 and grade 2 we mostly prefer topicals, and the options we have are benzoyl peroxide is one of the most common topical agent we use, benzoyl peroxide, and systemic we have minocycline, doxycycline, tetracycline. So these are the systemic antibiotics. Then other retinoids group we use topical tretinoin and adapalene and tazarotene, but in oral we give isotretinoin. So alternative options are photodynamic therapy. These are like alternative but we don't use much. This is just for the lecture. Zinc, tea tree oil, and acne of any severity usually remains spontaneous by early to mid 20s, but a substantial minority of patients, usually women, may have acne into their 40s. Thank you. So if you have any kind of questions, you can ask. This is just a short lecture on acne. Acne is a very huge subject. Just for at your level, this much is enough.